hospital and for hospitalizations. And so based on some of the growth and development that we've learned about these age groups, that kind of works into talking about how we prepare children for hospitalizations and illnesses, how important family-centered care is. So making sure that parents are involved in planning, that they're involved as much as they want to. And kind of what are some normal expectations, things we can expect when children are hospitalized. So things that parents may find a little surprising even. Anything from regression, like we've talked about, to anger, to I guess even, well, anger toward parents or anger toward staff, and then being uncooperative. And so sometimes parents even feel like that they need to apologize. And that's what I see sometimes is, especially if you have like an adolescent or even older school age and they're kind of grumpy and they are not very cooperative, that's kind of part of feeling a loss of control. And so helping parents to understand behaviors that they're seeing and really assuring them that that's normal is comforting for parents. So we'll just kind of talk about some of these things again for families and children during hospitalization. So some of the stressors of hospitalization, and if we think about being hospitalized as a child, illness and hospitalization really are the first crises that these children who are sick might be the first crisis they're facing. You know, they don't have a lot of experience with coping skills or experience to rate pain on, or all those types of things. So this is the first kind of, I guess the first kind of stressful situation that they may be involved in. So children are particularly vulnerable to those stressors. And when we think about stress, we can think about it kind of two ways. Like we said, they're in a situation that is very foreign to them. Again, depending on if they've been hospitalized before. So it could be a very strange situation that they're in where they don't quite know where they fit in or how to behave or where their control is. And then secondly, that lack of coping skills. So the coping mechanisms that we think about. And if you think about it on a broader range, you know, any of us that are ill or put in a situation like going to the hospital or even being sick at home, we can have these behaviors as well, as far as being irritable and non-cooperative, just not feeling like ourselves. And in older children and populations, really thinking about the things that they're missing. So missing their friends and missing home and missing school and there was social gatherings and those kind of things. So thinking about really what you're missing out on while you're being sick too. So children's reactions to crises are all different, and we know that. And it really depends on their developmental age. So thinking back on what is their cognitive level? Are they pre-operational? Are they into operational or concrete operational thinking? Thinking about their previous experience with illness. You know, is this a child, again, who's never been hospitalized, even depending on if they're 5 or they're 17? Or is this somebody who has a chronic illness and may have different coping skills than someone who hasn't been ill before? And then thinking about can't even talk tonight, sorry. Separation from parents, from family, from friends, and then hospitalization, being in a strange environment. I don't have my stuff here. I'm wearing this gown, or maybe I'm not wearing what I usually wear at home. I'm kind of restricted to being here. People I like aren't here. The things I like to do aren't here. And there's people coming in and bothering me all the time. So thinking about that, and then thinking about those acquired coping skills they may have. And of course, we know developmentally, as we get older, we develop more coping skills, but any of us in a situation we've never been in before, we don't quite have the coping skills developed for that. And so it could also depend on how serious the illness is for the child. So again, if they're extremely ill, very ill, then they might not have some of these behaviors that may be seen in children that aren't quite as ill. So if we're extremely ill, we may be very kind of lethargic. We may be not wanting to eat, to drink, to socialize, those type of things. And then what kind of support system do they have available? Do they have a parent that's staying with them? Do they have family that's coming to visit frequently? Do they have someone they can depend on to come? So that really factors in a lot how that stress of hospitalization is going to affect them. So the book talks about some levels of separation anxiety. And we can kind of think about these being the younger child. So thinking about it being kind of middle infancy to preschool years. So being anywhere from 6 months to 30 months. So 6 months to almost 3 years. And so we know that at that age, really, they're not able to think about situations being temporary or even be able to conceptualize if mom and dad aren't within my sight, then they'll come back later. And so that's what's so distressing many times on children that age. So the first stage they talk about is protest phase. And this is what we traditionally tend to think of when we think about that a child is in a situation in the hospital. Even it could be, you've seen this, maybe if drop a kid off at daycare when you're trying to kind of break away and leave, they're in the protest phase. They're very upset, they're crying, they're clinging to parents. And so that's what we typically see in this age group. What happens is that this may happen every time they see the parent. It may even happen when the parent comes back, because again, they develop and remember those feelings of when the parent left. And so they start to cry again when they see the parent come back. And some parents can even think that, if I don't visit as much or I don't stay as long, they won't be as upset when I leave. If the child has to be there for a few days or a week or even longer, that I just seem to be making them more upset when I come. So maybe it's better that I don't come as much. And that's not true. So children really need that support system. And so basically what they're going through at this stage is that trust versus mistrust. And so even though we think that trust versus mistrust kind of ends at about a year old, in a new situation, we talk about some regression. And so in this strange new situation, are mom and dad coming back? Are they coming back to visit? Are they here to comfort me when things are painful, or when I feel bad? Okay. And we know not all parents can stay the night and be there 24 hours a day with their child. And if they can't, encouraging them to do other things like coming in to visit, making sure that when they are there, that they know how they can comfort their child. For example, it'd be really scary to walk in and see a child that's in intensive care unit with lots of IVs and tubing and all those kind of things. So visually being able to show them how they can comfort them, how they can hold them, things that they can do so they don't hurt the child. They may be scared that if they try to hold them or hug them or squeeze their hand, that they might hurt them. So showing them how that they can comfort them in even strange situations. Now the second phase, despair phase, is kind of where that crying stops. Now it says evidence of depression. So what we want to think about here is that we know that if we take our child to daycare and we drop them off, that they cry and cry and cry, but we're assured that as soon as we leave, about 5 minutes later, they acclimate to the situation and they start to play with other kids and they stop crying. This doesn't mean they're depressed. So what this means in this despair phase is really that due to that separation and that anxiety, the children kind of have a change of behavior. That can be that they're uninterested in things like food or play, that they distance themselves, that they don't trust caregivers, those type of things. We tend to see the things that are changing to a despair phase and even into the denial phase. This is where we're talking about children that are separated from parents for a long period of time, or they're not consistently having their needs met, even by kind of a surrogate caregiver, which could be the nurses that are attending to their needs. So when we think about these things, this is not traditionally what we think about. It's just when we leave them for a little while and then they kind of start playing with other things. This is where they're starting to really not develop that trust. They're starting to have that mistrust. And so they are kind of backing away from things that they enjoy. In the detachment phase, that's really, it says a resignation, but not a contentment. So it could be children that we see that are kind of flat affect, children that seem withdrawn, even in the presence of the parent coming back, they don't really seem to have an attachment. And this could be really an evident that the child does have that mistrust, that they've kind of developed, I guess, in that cycle of mistrust and their needs aren't being met. So they don't see that kind of excitement or even excitement to even cry when parents come back, because they don't have that trust that the parent coming back is going to change and those needs are going to be met. So these are some of the things we really look for in seeing not only does the child, are their emotional needs not being met, but it could be even indicate some kind of a cycle outside of hospitalization of the child not having their needs met consistently by the same person. Okay. One of the things that seems to happen too is during the first stage of this separation anxiety, this protest phase, this crying, this screaming, this kind of clinging to parents, we tend to want to calm them down. And so as caregivers, sometimes we tend to think about that's the phase that we want to avoid, is them getting all kind of upset. And then if they are in this kind of detachment and we have a child that really doesn't cry, then sometimes we think, well, that's a really good child. But inevitably, if we think about that age group of where they're at, some of those things like not crying and not making eye contact and really not showing emotion when parents come and go, that could be that they are kind of in this detachment phase where they've not had their needs adequately met by the same people. Okay. So these are just some pictures. That first one on the left is the separation anxiety of the protest that we traditionally think about, and that's normal. And parents many times get more upset than the kids do as far as being separated. And so that's why in the hospital we think about how can we try to decrease the amount of separation anxiety that these children have. So what do you think are some ways we could decrease the separation anxiety for hospitalized children?
Giving them something from home.
Yeah, that's a great idea. So we know that children, especially children that are infants, toddlers, preschoolers, they equate objects with people and with home. So having things from home that they're comfortable with, having blankets and toys and stuffed animals, those kind of things that they are comforted by with them, is something that can kind of bring home to them. Yeah. What else could we do?
Play with them.
Keep them busy with play.
Definitely. So play, that's a wonderful thing. And so we know that part of their growth and development is play. That's how they're learning about the world. So learning and being able to determine based on their developmental age, what kind of play is, number one, safe, but is promoting growth and development for that age. And so having them to access to play, we'll even talk about access to other children and play. So having those social needs met. And then also another thing is that rooming in. So even having parents to room in and stay with children, be able to comfort them. We said before we were talking about toddlers that, you know, we can probably do a whole physical exam in a parent's lap. So if they're able to do that, and even depending on how much hands-on that they want to do, again, depending on how sick the child is as well, how severely ill the child is, it's a great opportunity for learning for the parents, as well as not only the child learning some coping skills, but the parent as well, being able to have a sense of accomplishment of learning things about the disease process and behaviors of the child, being able to build a rapport with the nurses and the staff, and you know, being able to have a different kind of bonding experience with that child. And not saying this is the greatest place for a bonding experience, but pretty much when children are not separated from parents, we found out that they can cope with just about anything. So rooming in is something that just happened really within the past 15 years. Before that, it was visiting hours and all those types of things. So we know not all parents can stay. And again, if your child is in the hospital overnight or 2 days, maybe much more likely than if they're in there a week or two. Again, knowing developmental levels, knowing how to meet the growing needs of children of that developmental age, we can bridge that gap of that separation anxiety. Okay, very good. So loss of control infants' needs. We know they're in trust versus mistrust. And like we've mentioned before, any kind of stimuli that they do not want, they're going to scream and cry. So whether they are being pricked in the heel for blood or trying to give them a bath, if they're not happy, they're going to tell us about it. So knowing again those behavioral norms of the infant. Having a consistent caregiver is important. So particularly the younger a child is, the more helpful it is to have a consistent caregiver, a consistent nurse that is taking care of the child. Being able to not only let the infant or even the toddler really get to know and experience that person, but also the more time you spend with a child, the more you are learning about their behaviors and their likes and their needs, and noticing things that may seem out of the norm or things like that. And so consistent caregiver to patient is always preferred if possible. And then daily routine. So we ask this big, long, huge health history and patient history. Of course, when they're younger, infant, toddler, preschooler, we're focusing most of that toward the parent. But as the child gets older and able to interject more and ask more of the child, then they can definitely start inputting as well. But knowing routine, so everything from when they get up to the type of feeding that they have, to how often they're feeding, to questions about stool and bowel movements and how frequency, favorite toys, what comforts them, what kind of things upset them, all of those different types of things can help us to develop a good daily routine for the younger child in the hospital. So toddlers, we know that they are developmentally and physically more advanced than the infant, but we're still in an age here where they don't have the ability to not only understand consequences, but they don't have the ability to think abstractly. So when we are doing treatments or providing treatments for a toddler, we want to make sure that the amount of time between talking about what's going to happen and when it happens is a very short period of time. Because if we talk about something at 8 a.m. and we plan to come back at 12 or 1 and do that procedure or take them somewhere, they're not going to remember those conversations and equate those two things together. So being patient. So with toddlers, many times if you are patient and let them help you as much as possible, it's going to avoid many more disagreements and them not wanting to cooperate and being very fearful. So if we're patient in the beginning, it kind of leads into more trust as we go along. Daily routine is still important as well. So even knowing what kind of shows they watch on TV, what kind of their favorite shows, or what kind of toys, what's the name of their stuffed animal, what kind of games do they like to play? So do they like to play where you're counting their toes, or do they like to play with their stuffed animals? Do they like to play where they're coloring pictures and decorating things? So what do they like to do, and what are they doing at home? Also talking about daily routines as far as siblings. So knowing about siblings and how old the siblings are, and if possible, to try to make arrangements for siblings to visit as well, or even to talk by phone or virtually through an iPad. Any of those things is kind of bridging that normal relationship of daily routine. Loss of control. So lots of loss of control with toddlers. Again, they may regress back into earlier behaviors, anything from sucking their thumb to baby talk, to having a big temper tantrum that they haven't usually had at home. And parents can be very confused by that, and they can also be apologetic for that. But again, reassuring them in these behavioral situations that it's a normal behavior, that it's a strange situation, and preparing them as much as we can for things according to their developmental age. So letting them hold the Band-Aid, making sure we're putting a Band-Aid on their boo-boo, all those types of things. But we wouldn't want to give them some big, huge explanation and overwhelm. Even at this age, the longer we wait between explaining and doing the procedure, the more kind of antsy that they're going to get. Negativism, again, no, 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 no is the favorite thing of the toddler. So instead of asking them, are you ready for me to listen to your heart? No, I'm going to listen to your heart. I'm going to use the stethoscope. Isn't this pretty? Do you want to touch it? All those types of things. So giving them an opportunity to not say no. So taking away that. If it's appropriate to give them choices, when we're thinking about the toddler, depending on really how young the toddler is, that may not even be appropriate for the toddler. But we know that another means is to kind of use that bridging technique, which is if they have a toy or a stuffed animal, ask them about their stuffed animal. Ask them if you can listen to the stuffed animal's heart. Ask them if they would, it would be okay if you listen to brother's heart or something like that. Have that bridging. If they see you with family members or doing things that are non-invasive, they can see that other people are building that trust, and that you're approaching them slowly. We also talked about temper tantrums. Again, like I mentioned, this may be a child that is so overwhelmed at this point. We can think about if they're in the hospital, they're not feeling well. And we know that when we don't feel well, we don't act our norm, or we don't have the coping skills that we do usually. And so they don't either. Regression can be any of those things like temper tantrums, where, you know, maybe last week they went to the doctor's office and the doctor listened to their heart and they were fine, but now they're losing it over it. Again, sensory overload, they're ill, coping mechanisms, all those things. We may have to work our way slowly into that. Okay. So I got a question here, and it says that Greg is 2.5 years old, admitted to the pediatric unit. His parents are making plans to visit as often as possible. Greg's parents complain to the nurse that the child cries, screams, and throws himself whenever they leave the hospital to eat. The nurse should do which of the following?
Normal response.
A.
Yeah, it's a normal response. And one of the things that we see too is it could be that the parents don't want to leave. So parents can get very overwhelmed as well. And so encouraging family members, parents to step out of the room at any opportunity that they get. Many times they are just waiting on you to say, it's okay, it's fine. We'll be finished in 15 minutes. We'll be finished in 20 minutes. While we're gone to x-ray, why don't you walk around, go get something to eat? They're waiting for that permission many times because they could feel guilty, or else they don't want to upset the child even more, so they don't leave. But just like we talk about in any other situation, those opportunities to have parents leave and come back, building that trust, is a normal part of development. So we want to encourage them to continue to do that.
With having a child that was in a NICU for over a month as a preemie, it's just as gut-wrenching to leave them, and you feel just as guilty, and they have no idea if you're there or you're not, you know, even if they were a toddler or whatever. I mean, it's just as hard.
Yes, I can imagine, definitely. Yeah, and I sometimes I think it even may be a little bit worse being a healthcare provider, because you know a little too much and you're trying to focus in on everything. But yeah, it's hard on parents. It's hard to leave, and so normalizing that behavior and telling them that's normal. It's okay. Go ahead and step out. Go get yourself something to eat, and then, you know, when you feel better or when you're ready and come back, it'll be okay. So as preschoolers, we know that preschoolers, a couple of things that we can think about is they're egocentric. It's all about me, 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 right? And they're magical thinking. So they could develop new fears even by going into the hospital. These are new situations and new fears. So we have to think about those things, like it being magical could add to fear, but we can take advantage of that magic too, right? So we've got this little boy here who's on a tricycle, or sorry, a big wheel, and he's got Superman. And then I think Jackie or Jamie had talked before about wagons and all those types of things. So we can take advantage of this magical thinking to build a rapport and to make them comfortable in a situation. Many times also, like we said, developing those new fears, it may take a little bit to kind of pull that out of them of what they're worried about or what are they thinking. So I think the book gives a really good example of sometimes asking them after something has happened, even to tell me how that made you feel, or to even ask the teddy bear, were you I don't remember what it said, something about asking the teddy bear of what did they think about their boo-boo, or what did they think about that band-aid or anything like that, to get them to say some of those fears. And sometimes they will, of saying, well, my bear said that he was, really scared when they gave him a shot, or my bear said that he was scared that when everybody left that nobody was going to come back. So sometimes, again, inadvertently using an object like a bear or a doll or something like that, they can start to talk to you about things that they're new fears. They may view illness as a punishment, or hospitalization as a punishment. Again, that understanding, that global understanding of illness equating to needing care in a hospital, is much more than they can understand. Even really understanding that germs that I can't see cause sickness, and so you have to come here to get medicine to get better. That's a big concept. And so they may think that the parents brought them there because they were being bad, or because they weren't doing something they should have been doing at home. And then pre-operational thought, again, knowing that we can't understand that global thinking or that abstract thinking or consequences, any of that. So when we're talking about what's going to happen or where they're going or prepping them for surgery, any of those things, it's very close to the time that those things are happening. Now, that's not saying that days before or things like that we can't start to introduce those conversations. We can, but we really can't go into the preschooler's room and say, remember last week when you went to the doctor's office and they talked to you about going to surgery? This is a new concept. It's a new situation. So we have to really talk about, again, here, of what's going to happen, and start to work in some of those ideas about things they could be fearful about. So separation from parents, so we can have parents stay with them and go with them and walk down the hall with them. We can also empower them, with magical thinking by riding in a wagon or on a big wheel or those kind of things. And so giving them opportunities to continue to explore and learn about things is important, but also being able to realize at this stage that they still fear, being separated from people that they love. They still want things that are comforting and reminders of home. They still may have regression at this age. And again, they may have new fears that they may tell you about as well. So school age. So we tend to think about school age, again, from about 7 to 12. And we say, well, these kids may not have been sick before, but they have been away from parents before. So they've gone to school, they've been around other peers. So they may have some kind of coping, but again, this is a whole new situation for them. So we need to make sure that, again, even though they're an older child, that we're keeping up with their routine. We're thinking about what's their norm, who do they usually interact with. So if it's parents staying or coming to visit, if it's friends from school, calling or on video, if it's friends in their class making cards for them, or if it's even them that are making art for their room, or a picture for their parents to take home, or a picture to send their friends. All those kinds of things are still about them learning and growing. With school age, it's important as well to understand what they're missing. So they're old enough to be able to understand what I'm missing. So school is something that they probably wouldn't tell you is their favorite thing in the world while they're going to school. And when they're away from school, that's their norm, that's their routine. So they may miss their teacher, they may miss their friends, they may miss going to gym or at art, or their just normal day-to-day routine. So thinking about how can we maintain that routine? If a child's in the hospital for a long period of time, or for an extended period of time, then we can even have someone that is in the facility that maintains school with them, okay? But it may be a child that's away from school for a few days or a week even. And so if they feel up to it, having parents to bring in schoolwork or bring in things that they're doing and learning so they can keep doing that. If they don't have scheduled schoolwork, but thinking about things they usually like to do during the day, this is a great age to really start planning a calendar for the day. So saying that, it's 8 o'clock in the morning and it's breakfast time. At 10 o'clock, we are going to come in and we're going to help you get washed up and make sure mom has everything and help you get washed up. Then there's going to be an x-ray this afternoon that's where they take a picture. When you're lying down of the leg that you hurt, they're going to take a picture of it to help us see how well it is healing or how good it's doing. And then there's an opportunity to go to the playroom today, and there's all kinds of exciting things there, as well as other kids that you can meet and interact with. So some anticipatory guidance for school age is really important. It's a part of them feeling control as well as their input on things they want to do. And so as well as talking to them about it, having a visual type of calendar where you can write in those things. Also making a list of things that they like to do. And so it's a good communication so that they can see that you're interested in the things they like to do, but also at a handoff report saying, this is Melissa and Melissa likes to do this, this, and this. And so it helps to provide some continuity of care. Fears that they might be having. So fear of death, abandonment, permanent injury. So the school age child as well is learning about their body. And so they know about things like their heartbeats, and they know about things like they need their muscles and their bones to be able to run, all those types of things. So if they have an injury or an illness, they can start to put things together that are half true and half maybe part of fear, and maybe some things that their friends told them and those kind of things. So clarifying things that they know, and then building up and picking up that information to bridge the gap of the things they don't know. So again, this could be the child that maybe they have pneumonia and they're having difficulty breathing, and so they are using an incentive spirometer to try to take big, deep breaths and all those type of things. And even though it doesn't have anything to do with their heart, they may ask you if being sick has made their heart sick, or things like that, because they're equating things in the same category of places where they are in the body. Or they may even ask you about things like if they have a cast on their leg, those type of things. They may be scared, like when you take the cast off, what is my leg going to look like? Or what's under this bandage that I haven't seen? So preparing them for things like that and giving some anticipatory guidance at this age with limited amount of information, that's really getting to be part of the control for them, as well as asking them, what are you thinking about when we're going to take this dressing off? What are some things that you have any questions?
I have a question whenever
Yes,
Jamie's done.
go ahead.
So there was 2 questions on the actual test that was actually from this slide and or what you just stated in the previous slide. So were those something that you already mentioned before, or is that we're just learning just now? Because I remember one of the questions was schoolwork.
Yes.
So we're just now learning that.
No, these were things we talked about back when we talked about growth and development of the ages.
Oh,
so when we talked about school age, we said maintaining that that school is important to them. School is part of their structure, and maintaining that structure. Yeah.
Oh, okay. And I can't remember the other question. I know it was a bullet point from the previous slide, but I can't remember that question either. All right, thank you.
You're welcome. Yeah, some of this is kind of pulling for some of those things we talked about, the age groups. And so thinking about those things, if they do have fear of death, fear of abandonment, and they're in this strange situation, how can we help them to adjust to that situation? And what kind of things based on this age group can we think about that can help them to get more control over their situation? Another one it lists here is boredom. And so this is the age where you start having them, I'm bored, I'm bored, I'm bored. So thinking about things they like to do at home, even starting at school age, they're very active with electronics, whether it be computers or video games or watching movies or all those types of things. So those kind of things are still things they like to do in the hospital. So having them bring those things from home, or even if we have those things in the hospital, those are things that they may enjoy doing. So eliciting, like we said, things they like doing from both the child and the parents, and being able to elicit what are the things that we have here that we can bring in, whether it's modeling clay or Legos or painting or any of those things, or things that maybe parents want to bring from home that they like doing there. So they already have kind of their same stuff, and they know, what they like doing, and so they can bring those things from home as well. So adolescence, so struggling for independence, and what you may see in the adolescent is them trying to be very stoic and kind of tough about that they don't need their parents to be there, or it's not going to hurt, or I'm not scared, or any of those things, and even can get angry. But the anger at the adolescent stage may not be because they are afraid of what's coming or because the parents have left. It could be anger because we've disrupted their schedule. We've disrupted what is important to them outside. And that is part of learning to be myself, learning to be independent. And we're in a very dependent position here. It can also be the fear that, hey, my peer group, my friends, what am I missing? What are all they doing at school or at home or going out, or all those things that I'm missing? And the true fear being that, how am I going to come back and fit into that situation if I've been gone? Will they forget about me? Will they move on from me? So seeing that anger and frustration, kind of eye rolling and I guess making comments maybe about, weren't you all just in here? Or everybody keeps coming in here, all those types of things. So thinking about what kind of things are they feeling a loss of control about? Privacy, independence, making choices, being able to plan part of their schedule, seeing peers, all those types of things could have them cause a loss of control. So how can we kind of mediate those things? And so, like we said, think of all the number of ways they can communicate with their peers. Doing the things that they like. Again, it could be things like computers and video games, but it could also be fear of looking different. So many surgeries or many even types of illnesses, at this age, we all want to fit in. We want to be independent, but we want to fit in. So it could be fear of scars. It could be fear of not being able to participate in sports like they could, not being able to return to school and return to their friends and the normal kind of things that they did before. So how long will it be before I can go back to hanging out with my friends, before I can drive again, before I can eat real food, before my surgical incision, is it going to have a big scar? All those types of things are things that they want to know. So anticipating at this age, what are their concerns, helps us to be able to address those things instead of just waiting until maybe they bring those things up. Now, anticipatory guidance is really good at this age. So we can talk about something yesterday that's going to happen today. And then today we can reference what we talked about yesterday. And we can say, okay, now remember we talked about that you were going to go down and have that CT scan at noon today. So do you have any questions based on what we talked about yesterday? We talked about that you're going to be in there for a little while, and they're going to be looking at your chest. And so based on that, they're going to come back and see if I don't know, they might need a chest tube. I don't know, something like that. But again, thinking about filling in the gaps for them, asking them about their concerns, giving them enough information that they need to know right now, but then also following up afterwards. Was there anything that happened that you made you nervous, or that you didn't understand, or any questions that you had? And then even following up, particularly on our older adolescents, to say, what does that mean? Why did I have that test? Why did I have that blood work done? When am I going to find out about when I can go home, or what is between me and going home? All those kinds of concerns and things are questions that we may get, as well as things we need to be addressing at this point of what's going to happen today, what's going to determine, when I get to go home, or things like that. So fear of bodily injury and pain. And again, to some aspect, we all have this. So are our fears based in the things of the fear of the unknown, or are they based on things that are truly going to happen? So we know that children's fears, particularly when we're thinking about school age and younger, a lot of it can be based on fears of the unknown. I don't understand maybe why I'm here, or maybe who these strange people are, or why I don't feel good, or why I have to keep having this medicine, or why you're taking blood, or why I've had the same x-ray twice. So fears, again, can be based on what they understand at that developmental level. And then again, it could also be based on what's their history of being sick, of being in the hospital. Children that have been in the hospital many times, or that have a chronic illness, maybe asking us different things and have different concerns than the child who hasn't. So it could persist into adulthood. Again, trusting caregivers or healthcare providers, not trusting healthcare providers, being truthful, not telling them something's not going to hurt when it might hurt, not rushing them, being patient, not judging them for their behavior. So again, if we have an adolescent that starts to cry and get upset because they don't want us to put an IV in, we don't want to say, all the other adolescents that I have up here, everybody else that's 15, nobody else acts like this. Or you're almost an adult, you shouldn't be acting like this. Those kind of things stick with you as far as how people treat you and how you are respected. So we don't want it to cause, in the short term, more problems with this child coping during this hospitalization. But as they get older, really not having that trust in the provider. And so that if they don't have trust in healthcare providers, they may not keep doctor's appointments. They may not keep up with preventative screenings. They may not take medications as instructed. Building that rapport and that trust from an early age helps to tell an individual that, we're somebody that they can trust, somebody they can tell personal things to, they can tell embarrassing things to, and that we can give them truthful, honest information. So the effects of hospitalization. Again, how can we bring home and the normal schedule to this child based on how ill they are, based on if they're in an isolation? Any of those things could be, are we going to allow the child to be as independent as possible, to go to the playroom, to ride the tricycle, all those things? Or is their circle of independence even smaller because maybe they're immobilized, maybe they're in isolation precautions, maybe they are really, really sick, and so they're not safe to be up moving around. Maybe they're lightheaded, maybe they're short of breath, all those type of things. So the effects can be seen at different periods during hospitalization. Remember that just because we know the plan of care, just because we see the doctor's orders and we know what labs they have, and we know that after this surgery they should go home 3 days post-op, the child doesn't know that. So we may have to repeat things for the parent as well, repeating what expectations are, answering questions repeatedly. If you're stressed, if you're the parent that's stressed, you may ask the same question a couple of times. And that's kind of a normal thing, that we're under lots of stressors, as well as they may need reassurance more than one time, okay? And the child may need reassurance continually every time that we have to take a blood pressure, every time we have to give them medication, or we have to look at their wound. that continual kind of anticipatory guidance and reassurance, and even that building some type of coping skills with knowing that they did a great job. Even if we can pick out some of the things they did well with and praise them for that, we don't want to emphasize the negative things, okay? Their concept of illness is more than their intellectual maturity in predicting anxiety. So again, it could be based on a lot of things. Maybe they had a bad experience before going to the doctor. Maybe they had a sibling or a friend that was really, really sick. Maybe their parents been really sick. Maybe they have seen things on TV that have really scared them. Maybe they, again, like we said, is tired or sick or those kind of things. So some of our behaviors aren't typical of what we think of with the average school-age child or adolescent child and those type of things. So with this type of problems or anxiety, stress with hospitalization, we've talked about some of the ways that as a nurse we can help with that. And just like anything, if we think about that we have a problem to solve, we need to start with assessment. We need to assess. And so assessing, again, the normal routines of the child, the questions they may have they been hospitalized or injured before? And then again, making sure that our continuity of care, whether it's with providers, say nurses, whether it is with, again, eliciting what they may be calling something, so a boo-boo, or they may be calling it my piggies, my toes, those kind of things, continuing that kind of conversation with them. And then we're giving report, sharing that information about that child. We have to spend time with them to get that information. So we want to make sure that we're not in a hurry, we're not rushing, we're not impatient, because our anxiety and our hurriedness increases anxiety in children and families.
So how is this all kind of done now through COVID? Or do you know by chance? And I know a lot of lack of visitations and contamination and all that kinds of stuff. How has it been different?
Well, children should still be able to have one caregiver that can stay with them. Anything anybody else wants to add as far as how it's been different during COVID?
My mom is a peds nurse, and it's one parent or guardian per day. So if the mom comes like in the morning, the dad can't come later. It's only one per day.
Okay.
I work on the floor on floor East at UK, and we're up to 2 parents at UK.
Okay.
But they have to be like legal parents or guardians. You can't have like siblings or aunts or uncles or anything like that.
Okay.
Yeah, and I don't know about the kids, but one patient or one visitor per patient from 9 to 5. They leave, they can't come back.
Okay.
The only way they're allowed more is if they're terminal.
Okay. Okay. That's a great point. So again, it may depend on how ill our child is too. So I know a lot of healthcare environments, whether it's peds or whether it's in the adult care, whether it's in the nursing home, those kind of things, the visitation restrictions may be different if we have a terminal child, a child that is really, really ill. So we would probably need to find out. We're going to say something, Taylor?
I was gonna say at Children's we're back up to 2, and like I've seen the kids even walking around the hospital or getting wheeled around with mask on, and the parents as well.
Okay. Okay. Yeah. That brings up kind of one of the things that is important is when we think about decreasing stressors, some of that basic information that can decrease all of those questions that sometimes they may not even think of when they're admitted to the hospital. So we're going all over those kind of orientation questions about who can visit, how they arrange to visit. So do they have to have a mask? Do they have to call ahead and make an appointment? When mealtime is. Maybe it's an adolescent and parents want to be able to bring them something else, or whether it is being oriented to the unit or where elevators are or public restrooms are. Sorry, guys. Where there is places to get food in the hospital, all those types of things. Let me scare them out. Hang on just a second. Okay, they didn't want to play nice, but I think they'll sneak back in. So thinking about all those things that can decrease some of those just environmental stressors as a good orientation. And then as plans change, as things change, of course, as they may move units in the hospital or may go from their room to surgery to waiting for them in recovery, all those things require a new orientation. One of the things I'll just kind of interject here that I found as being the parent of a child in the hospital is, and really anybody, is that if you can walk somebody at least part of the way to where they're going, instead of just saying, oh yeah, it's there, and you go there and you go there. If you are with somebody who's ill, you can only retain so much information. So thinking about that, thinking that people are overwhelmed or they're stressed, and if it's a complex kind of instructions you have to give them, write it down, or at least try to walk them to the elevator, walk them part of the way, and help them to figure out where they're going. So individual risk factors, again, this could be based on a number of things. It could be based on not only the developmental age, but it could be based on if they're familiar with healthcare at all. So maybe they are a child that has been type 1 diabetic, and maybe they've never been in the hospital, but they've been to the doctor's office quite a bit, and they're comfortable with the doctor and the nurse. They've got some kind of a reference to being around healthcare professionals. It could be based on personality. So the book kind of talks about temperament, and temperament really being kind of what they label as being an easygoing child versus a difficult temperament. And so we tend to think about things like an easygoing child as being somebody that's well acclimated to the environment. They don't have any stressors, they're not complaining, they don't look distressed. But if it's a child and they're not saying a whole lot, it could still mean that they're extremely, extremely stressed. They just don't know what to say or how to say it or who to say it to. So asking about some of these things that could be asking about how they're feeling, or again, talking to them about things they might like, all those type of things can help to decrease the feeling of stress, whether they look the picture of stress or not. When we think about what they call the difficult temperament, it could be the child who is very vocal, the child that maybe in this no phase, maybe pushes away from things, all of that. But if we think about that, that child may be the one who is exerting their independence more, is saying no, is setting boundaries, is showing their anxiety. So the two children may look different, but they both may have anxiety. So when we think about behavior alone and thinking about kind of this temperament, we want to make sure that we're not taking just face value of what somebody might be feeling inside. It also talks about increased vulnerability of stressors being a lack of fit between the parent and the child. So again, if we can notice that in some instances where we said that the child really wants a parent to be there, and maybe the parent doesn't feel comfortable and they want to step out a lot, or the child maybe has the parent there and they say, I wish mom was here and not dad, or I wish dad was here and not mom. Maybe the parent that's there is very, very anxious as well. And so if we're trying to calm down and decrease stressors, we can't forget parent. So the parent may be kind of anxious and things like that and rubbing off on the child. So decreasing anxiety in the parent and the child, so that we can help kind of be able to care for that child in the least traumatic way possible. And then age, we've talked about that early developmental age, and this even talks about 5 years and less. They're that, preconceptual idea. They're not even concrete operational, they're pre-operational. So they can't even equate things like categories of, they put the pulse ox on my finger and it didn't hurt, so I know when I see it again, it's not going to hurt. They are not even there yet. So they can't even equate this, that, you look at the stethoscope and it didn't hurt, so the next time I come back in, why are they upset again? Being able, again, to be patient and to not only give some kind of maybe anticipatory guidance about what's going to happen, but we also need to think about safety here. So in this age, those are going to be the children that, even though they may look kind of calm, may be very likely to pull away or to jerk or to push a needle away or something like that, because it's just an instinct of being scared. And so having another caregiver, especially if we're thinking about a child 5 or younger, 5 years old or younger, if we're going to be doing something that requires them to hold still and not to, again, push away from it, it's a very good idea to do that. Okay. Male go ahead.
One of the questions on the test was about a spinal tap and what should you do with a wiggly 7-year-old? And my answer was, for a spinal tap, you'd have a second set of hands to hang on to them. Would that be?
I had that question too, because that's what I thought you were always supposed to get another nurse, but I got it wrong.
I got it wrong too, and I picked that answer.
I'm
Me
glad
too.
I'm not the only one.
I'll have
Same
to go
here.
back and look at it. I honestly wish I could. The question's familiar to me, but I can't remember all the stems. So I will go back and look at it. The thing with ATI as well is that I have to type in every question, every stem, and everything. So it's a possibility that it could have been keyed wrong. But I'll go back and look at them, and then definitely keep that in mind so that when we come back on Wednesday, if you have particular questions, I can address them. Based on that, and again, I can't remember the exact question, but we do want to make sure that we are keeping children safe. And like it says here, 5 years and younger, but depending on what we're doing, right? If we're doing something as invasive as like doing a spinal tap or putting a chest tube or something like that, I mean, we need to make sure that we're keeping them safe. Okay.
I think this question was a 7-year-old. Yeah, they were 7 and they were upset about having to be bent, where they were going to be positioned or something, and to that effect was the question.
Okay, I'll go back and look at it. Okay. So the book even talks about the male gender being vulnerable to stressors. And so there's a couple of reasons that they could see that. One of the reasons is that particularly when we're thinking about, like we said, school age adolescents, that the male gender really has been conditioned to be a big boy, don't cry, be tough, all those things. And so they may feel more, I guess, more pressure to be more stoic, to try not to cry, not to ask questions, not to tell somebody if they're stressed or upset or all those types of things, in where traditionally we kind of tell little girls that it's okay and they're, you know, it's okay to express feelings and all those kind of things. So we do want to make sure that, again, we're not judgmental about feelings of stress or anything else, and that we can anticipate, even though that they're not saying anything or that they may look relaxed, that we're still giving that anticipatory guidance about things and offering an opportunity to ask questions or to, you know, to ask about anything they might be concerned about. Below average intelligence, again, with this, we can think about kind of a cognitive level of how much are they able to really understand. What are their I guess their norm level of functioning? Is it, again, how do they communicate? So is it a child that understands verbal communication? Is it a child that's comforted in a certain way? So again, a child that may be older but may be comforted by being rocked by the parent, by making sure that we are explaining things at a developmental level for them. Yeah. And then multiple or continuing stressors. Again, lots of stressors. Thinking about, even when we talked about the well child of school age who's under lots of stress. So there's other stressors other than being just the hospitalization. Again, it could be the stress of, am I going to die? When can I go home? Am I going to be able to play sports again? When can I go back to school? How am I going to wear clothes with this big ugly cast on? All those multiple stressors. And then thinking about, we talked about the very young child, that separation anxiety being the big stressor. And then as we get older, it's that lack of independence, lack of control, and then kind of the fear of missing out that can be biggest stressors. So there can be benefits to hospitalization. And so when we think about it in the midst of illness, it may not be obvious to a parent or a child at that time, but recovering from illness and experiencing certain types of situations and behaviors can help to build a level of confidence, and it can help to build a level of confidence even with each experience of, you know, you helped me hold that Band-Aid, or I really like those questions that you asked me. They were so important. I like how when you got that shot, you held mom's hand because she was really scared. All those types of things. So having small victories as we're moving along is important. And then being able to see themselves kind of make it through situational stressors. So going in and having my tonsils out, making it through spending the night in the hospital, all those types of things. As we get into really the school age, adolescent, those kind of things, those are things they brag about. I was in the hospital. They had to, my leg was broken. You should have seen it. I had this big cast. Do you want to sign it? All those types of things are building on coping skills. And so with those increased coping skills, again, depending on what age group we're at, it is really helping to reinforce the things that they're learning at that developmental age. So even thinking about their normal types of growth and development at that age, whether it is trust versus mistrust, whether it is that guilt versus initiative, or the intimacy, or any of those type of things, what our milestones are at that time, we need to take advantage of mastering those types of accomplishments. And then it says mastering the stress and feelings of being confident and coping. Again, it could be the school age, adolescent, again, that maybe, well, really any of the children, if you think about maybe older preschool, but when we get to school age adolescents, that maybe they may have a reoccurrent illness. So maybe they may have been diagnosed with diabetes. Maybe they've been diagnosed with a stomach problem that they have to go back to the doctor for, that they may later have to even go back to the hospital for, all those things. Now they've got a baseline. Now they know somewhat kind of what to expect, and even able to have a little more control over their situation. And then new socialization experiences. So learning to trust nurses, doctors, being comfortable, learning new things and asking questions, socialization even with other kids in the hospital that are like me, who may be on crutches, who may be in traction, who maybe don't feel good. And so we're in the hospital at the same time. All those types of interactions can help them to build those new skills and even use that as a baseline for their next type of stressor that they interact with. So parental responses to stressors, again, they could be upset. So that disbelief, that anger, that guilt could be based on, could I have avoided this? Is this my fault? Should I have seen the warning signs about this sooner? Should I have known yesterday when they complained about a stomachache that it was really their appendix? So kind of the guilt and maybe being upset with themselves that they just thought the child was complaining, or maybe that they told them that it was the first time they could go ride their bike out around the neighborhood or something like that. So they could feel guilty. They also feel guilty if they can't stay 24 hours a day. So again, being able to reassure about how they can keep in communication with the child when they can come back, helping us to be able to know when they can come back so we can inform the child of how soon it is till they come back. Could also be parent who has to go home and take care of their children. Fear and anxiety related to their pain and their seriousness of their illness. Again, providing accurate information. So being able to not only give them information about what's going to happen, but that is happening. Anything from fear and anxiety to seeing their child ill. So one of the suggestions that's really good is when the first time the parent sees the child is a nurse or someone should go with them, be able to answer questions and explain things. Whether it's the child that has an oxygen mask on, that's extremely scary for a parent because the child maybe isn't communicating, or whether seeing a child with IVs and things like that. If a child comes in and from an accident, a trauma or something like that, it may be that the hospital, the ER, ICU, wherever they've sent to, has to get them kind of ready and stabilized and all those things before parents can be allowed to come in. And so that period of time may be very anxiety provoking as well. Getting new information, thinking about the stress of seeing a child that's ill, and also what is all this stuff? And am I going to hurt them if I touch them? How sick are they really? All those type of things. And then frustration. So related to need for information. And so important about that anticipatory guidance, giving parents and even older children an itinerary of what's going to happen. So this is a great idea when I think about it, even with adults, of you come on to shift, you get to see what the orders are, what the plans of the day are. And many times people just keep it to themselves. So they're going to have an x-ray in a little while, but they don't tell the patient until they go in and say, it's time to go to x-ray, go to an x-ray. So going in and talking to parents, looking at your computer and saying, it looks like today is going to be getting ready for surgery in the morning. And so what that means is that Johnny is going to have an x-ray. We're going to be given some medication to help him clean out his bowels. So when he goes to surgery and they go in and look, that will be clean in there. They can see if there's any kind of bleeding or anything like that. So what that also means is that at 6 o'clock tonight, the diet is going to change to a clear liquid diet. And so what that means is he's going to be able to have things like popsicles and juice and Sprite, all those type of clear things to help get kind of the bowel cleaned out. And then at midnight, we're not going to have anything else to eat or drink till surgery in the morning. So even though you know that when the nurse comes on tonight, she's going to talk about what's going to happen at midnight, giving an itinerary of what's going on during the day and answering any of those questions from that whole shift at the beginning of your shift helps to involve them in the plan of care. So at that time, they can say, well, I don't know, Johnny's diabetic. Is it okay for him to not have anything at midnight until the morning? Is he still allowed to take his medication? We might have questions too. So that would be like, that's a really good point. And it doesn't see anything on here about continuing his medicine tonight. So let me call and ask about that, and I'll definitely let you know. And then, so being able to really talk about the plan of care and involving them and what questions they have. What time is surgery going to be? Do you think I need to stay tonight, or is it okay if I come back in the morning? All those type of things, in that it really is family centered. It's not, this is our hospital and you're coming here and we're going to do things to you and we'll let you know when you need to know things. It really is family centered. Okay. Also can be depression. So thinking about stressors of the parent. Again, the stress of their child being in the hospital. Could be the parent has to work. Could be that they are worried about medical expenses. How am I going to take care of them when they go home? How am I going to get them into the house if they are in a wheelchair and I don't have a ramp? How am I going to tell the other kids at home that he's going to have to be here a little while? How am I going to not feel guilty about being here when the other kids are at home, or being at home when they're here? And all of these kind of stressors may be things that the parents want to talk about, or when you definitely ask them those open-ended questions of, is there anything else that I can help you with? Is there any information that you would like me to find out? How are you doing today? Tell me what's going on with you. Any of those things could be somebody that just says, blah, and is waiting for somebody to ask. And it could be something as simple as needing reassurance that it's okay to step out. It's okay to go to work. It's okay to go home and take care of your other children. It's okay if you can't come back after work and you have to go home and you want to call and FaceTime. So all of those things, it's okay to call anytime and I'll update you on the plan of care. All those things are extremely important in providing information and decreasing stress. Okay? Even if we've been parents for a really, really long time, many times we need reassurance about a new situation, and that we're doing the right thing, or we did the right thing. Okay? Sibling reactions. So again, depending on the age of the child, it could be a younger child who doesn't understand where my siblings gone to, where mom and dad are gone to, why am I at grandma's house? And we can see a regression of behavior of the kids at home. It can also be that they're separated from parents. Again, it could be that they are scared. Maybe they're at an age of preschool where they understand that brother had to go to the hospital and they don't know if he's coming back, or they don't know if he's gonna die, or excuse me, if they're going to be sick and have to go to the hospital. So lots of different reactions of siblings. When we're not COVID, a great opportunity is for siblings to be able to come in and spend time with their sibling in the hospital, to be able to see that the people that are there are nice people, to be able to answer their questions, to be able to have them look around and see the environment. So when they go home, it's not a fear of the unknown. Many times hospitals will even have playrooms that the siblings can go to with their person in the hospital to play in a playroom. The kid in the hospital can even show them around to things, those type of things. So when they're able to visit and really see that environment and have questions answered, it can decrease some anxiety. Another thing that can happen is they can have some resentment and some jealousy. So it can even be that they maybe don't understand why parents aren't there or spending time with them, or it can even be a child who does understand, but it's not fair. It's not fair that you can go to my baseball game, or that you can help with my homework, or that you're never here at night. You're always there, okay? And so we can see some anger, we can see some jealousy, we can see some guilt. Again, maybe even about a child who was injured, if another child was there, or if a child who was sick and they feel like maybe that something's happened to a younger sibling that they were supposed to protect, or that they maybe didn't know they were hurt or sick, and they didn't call mom or dad until they came home from work, any of those kind of things. So any of those kinds of emotions. So even helping parents to understand that, asking about kids at home. Are there kids, do you have other children at home, and how are they dealing with this? Do they have any questions? Do they have, are they upset or anything like that? And parents may even express to you, you know, it's hard when I go home because my 3-year-old is really upset and doesn't want me to leave, and said that he doesn't want me to go anymore, and all those types of things. So talking about some of those things that are stressors at home. Talking to parents about what's normal for siblings as well. Altered family roles. So again, it could be that the child in the hospital comes home and maybe they aren't the youngest, and the youngest child is maybe used to getting a lot of attention and things, and now the child that's ill or has a new maybe a new chronic illness where they have new behaviors, so checking blood sugars, new diet, all those kinds of things, they're getting more attention than the other child is. So information is important to siblings as well. Talking about kind of realistic expectations of things that are happening, again, based on developmental levels. Could be talking about why we are trying something new to eat, why we do have to make sure that I don't know, maybe the one child is going to be home from school for a while, and then they say, well, it's not fair. Why do I have to go to school when he doesn't have to go to school? So all those types of things. It can even be that maybe the sick child enjoys the attention, and they were in the hospital and they were sick and now they're better, but they came home and they still want to continue having mom and dad wait on them and help them and all those kind of things. And sometimes that is a normal post-hospital behavior, a fear of doing things for themselves, fear of hurting themselves, not quite feeling themselves since they've come home. But having parents to ease them back into the norms of what they should be doing. And even a child as young as a preschooler can wash their face. So involving them the entire step of the way on what they can do and what they should be doing, and the correct way to do it if they're worried about hurting themselves. I'm afraid to wash my leg. I'm afraid that this big wound will open up or something like that. And then parents continue a pattern of overprotection or indulgent attention. And again, post-hospital, in the immediate term that may be a norm of adjusting to a new situation again, but also talking about whether we're in the hospital or whether it's even post-discharge, maybe at home health or at a physician's checkup, of getting back to the norm of how those things that they do during their daily life, whether it is washing and bathing, getting dressed, doing schoolwork, all those things are part of growth and development. And so we want them to start doing those things for themselves again. It doesn't mean at all that you can't stand by and offer assistance, or you can't say if you, get to something that you're taking a shower and you're scared about stepping out of the shower, that you can't yell for me, all those types of things. But we want them to be able to resume their normal activities. Okay? Important information really at discharge, and also, like we said, when they're doing their follow-up appointment with a physician, of how are things going, of getting back to what you were doing before. Okay? Preparing for hospitalization. So we said assessment. All of our assessment from the very beginning of doing our inpatient assessment should be assessment every shift of coming in, seeing where the patient's at, seeing where their concerns are, seeing how their day went, how their night went, questions they have about what's going on during the day. Also, every shift we want to reassess our nursing diagnoses. So are they still in pain? They had pain last shift. Are they still having pain? Is that still our primary diagnosis? Or now, when we're trying to get up and move, is it mobility? So making sure that we're updating those nursing diagnoses so that we can keep track of what their most urgent concerns. And so the other healthcare providers can too. We talk about planning, of course, starts from the very minute they're admitted to what are they going to need during the hospitalization? What kind of things will they need at discharge? Do they need services as far as financial services to help pay for things? Do they need home health? Will they need a wheelchair ramp? Will they need a wheelchair? Will they need PT? All those things based on, as we're going along in hospitalization, we don't need to wait till the hour before they go home to know that this child may need a wheelchair, or they may need oxygen at home, or that they may need home health, do a home health visit. We can start bringing in those people throughout the hospital stay. Now, again, it's not always the nurse's responsibility to have to call and bring in these. What happens with a lot of providers, whether we're talking about PT, whether we're talking about home health, whether we're talking about all these kind of things, is that we talk to the physician about that we think the patient will need this, and they will make a referral to certain specialties. And basically the reason they do that is because if it's a physician referral, then that service can charge as they come in. So if we just called PT and said, gosh, I think they might need PT, can you come look at them? That's not a documented service that they needed. The physician has to write an order for that. So we're the ones with this patient all the time. If we see this patient is having difficulty with mobility, that they may need someone to come assess and come work with them. If the parent says, I'm just really concerned about going home and taking care of this wound, I don't think I can do it. I don't think I can pack this wound, or I don't think I can give this medicine. Well, let's talk to social services, and then they can get a referral for home health. So we can start identifying these things as we go along, and definitely teaching every single time we are with that patient and family. And then implementation of doing those things, documenting those things, passing that on in referrals to the next nurse coming in. If we're teaching them something and we need to document why we taught it, what kind of brought that on, what are we teaching specifically, and what was their response to it. So let's say we have a patient comes in and they are diagnosed with type 1 diabetes. We don't want to wait till they're ready to go home in this afternoon to say, wow, we got a lot of things to teach you about diabetes. We want to start introducing that. And what's really helpful is that if we are doing those things during the hospitalization, maybe we're checking blood sugars, we're administering insulin, we are looking at what is a diabetic diet. We can start teaching as we're doing, and then start to bring the parent, even bring the child, if it's maybe an adolescent or maybe a school-age child, to checking blood sugar, letting them start to do it with us and getting them comfortable with it before they go home. So that whole period of being in there is an extreme learning period. And we want to document that as well as pass that along in shift change so that they know where we left off and where they should pick up. Okay. And then definitely evaluation. Always go back and evaluate everything we did, from pain to knowledge deficit to ambulating, to everything. Do you have any more questions? Did they do what we had expected them to do in that goal? Whether it was the goal of expressing their anxiety about an x-ray that's coming up in an hour, or whether it is being able to ambulate by this time. We need to go back and evaluate and document. Okay. So preventing and minimizing separation. We talked a little bit about this. So under 5 years old, especially, we need to be thinking about our primary nursing goal is going to be helping them to, as much as we can, normalize the situation, and knowing how important that being with parents is for the children. Usually when we think about children 5 younger, then they don't have a whole lot of experience in spending a long time away from parents. Yeah, it could be children who go to grandparents during the day or go to daycare during the day or those kind of things. But these aren't usually kids that go to strangers for, you know, an extended period of time, or go to school all day long and have a normal routine away from parents. So spending time with parents is extremely important. And so helping to minimize that separation, even if it's during a procedure or walking to x-ray or walking to surgery, all those types of things. Knowing what family-centered care is. So family-centered care is about anticipating needs and helping to assess those needs of the child, the parent, answering questions and normalizing things for the child and parent. What is a normal behavior? What's normal blood pressure? How far should he be walking after surgery? All of those things, and then making them part of the plan of care, okay? So they're not just here staying with us while we do everything we do, and then we're gonna let them in on it. They are fully part of that plan of care. So updating about the plan of care, asking questions, giving them an itinerary of what's gonna happen today. Parents aren't visitors. Don't ever refer to family as visitors. And it's a hard habit to break, because I kind of think we think about visitor policy and all those kind of things. But don't refer to family, especially parents, as visitors. They're part of the plan of care. They're part of this family-centered care. And then, of course, we said bringing familiar items from home. They don't have to bring a million things from home. We can even involve the child in saying, what are some of your favorite things you want to bring? This may even be a planned admission where the doctor has talked to them about, here's some things that you want to bring along, whether it's outpatient surgery, here's some things you want to bring along, or when you're admitted to the hospital, here's some things you want to bring along. Here's some things you don't need to bring along. And then again, they don't have to bring everything from home, because we do want them to get out of the room and explore if they're able to, go to a playroom if they're able to, maybe try new things like Legos and building clay and painting and things they may have never done before when they feel a little bit adventurous. We say this normalizing the hospital environment, and I don't think the hospital environment is ever normalized, but normalized to the things that they're used to having control over at home, whether it is schedule, whether it's the type of clothes they wear. Depending on if they're going to surgery or something like that, they may be able to wear their home clothes, you know, whether it's pajamas or shorts or whatever from home. What time do they usually go to bed? What time do they usually get up? What do they like to do? Do they like to listen to music or play video games? Do they like to talk on the phone with their peers? So what is the norm of what they usually do? This is especially important when we're talking about school. So what times of the day are they usually doing school things, and incorporating those in there, as well as incorporating in that written schedule of things that are going to happen here in the hospital exclusively that you don't do at home, like physical therapy, like having an x-ray, like doing a dressing change, like taking a bath or taking a shower. All those types of things, when we see it on a schedule, we kind of know what's coming up. That's part of that control, is to know what's coming up. Bringing them in on when it should be scheduled. Now, we can't say we have to do an x-ray at noon, but I want to do it till 9 o'clock tonight. We're probably going to have to do it at noon if that's when they say we can come, is at noon. But if we're right in the middle of them, I don't know, playing basketball with physical therapy, we can say, I know physical therapy is usually at 9, but the x-ray's at 9, and when we get back from x-ray, we're going to call physical therapy, and then you'll be able to go to physical therapy. So some type of control and expectation about what's going to happen. little bit harder to do if we have a younger child. Again, preparing them as soon as possible to the event. So we're going to go to x-ray, they're going to take a picture, mom's going to walk down with us, you want to ride in the wagon, all those types of things. You want to bring your teddy bear with you closer to the event, better for the younger child. So nursing care of the family, again, we want to know what the family assessment is. We're going to ask about things that are not exclusive to the child. So we want to know about the family unit. We want to know about, who lives at home. Do they see both mom and dad if they live with mom? We want to know about, do they go to church, or do they have some type of religious beliefs that they want us to practice? Do they eat a certain diet? Do they restrict certain things like TV? What are the norms for the home assessment? We're also going to ask about history of things. So knowing about a child's history, we want to ask about a family health history, a family assessment of behaviors. Is there smoking at home? Is there alcohol at home? Do you use seatbelts? Again, don't shake your head like I did. That's a bad habit. Don't ever shake your head when you're asking a question, because that's leading someone. I just shake my head naturally, and it's not good when you're asking questions. Do you use a certain, tell me the kind of car seat that you use. Where do you put the car seat? So we don't want parents to feel like we're grilling them, but we do ask a consistent set of questions to find out, are there things that we need to know specifically for this stay in the hospital, or are there learning opportunities that we need to know? Could be home behaviors like smoking in the home that could equate to a child having asthma. And so making that connection about smoking, secondhand smoke, and asthma could be a real learning gap for them. Okay. Discharge assessment and planning, again, some of the biggest fear can be, how am I going to do this when I go home? What do I need to know when I go home? What equipment do I need to have when I go home? So talking about discharge and planning that throughout the care from the very beginning is going to alleviate some of that fear. Okay? If they have to arrange grandma to come stay, if they have to arrange for taking off work for a couple of days, if they have to arrange for maybe the child's bedroom is upstairs and they want them to stay downstairs. So they need some time to be able to make arrangements and to acclimate to those changes slowly. Encourage the parents' participation, again, planning, care. What kind of things do you do at home? What kind of things does he like to do at home? He's upset. What kind of things helps to calm him down at home? Maybe parents sing to him at home. Maybe they have music at home. Maybe the parents rock them at home. Maybe they want to room in and have a cot next to the bed. What kind of things do the parents anticipate would be helpful? Giving them information all the way from the very, very beginning. Assessment information about in the room. Where's the TV controls? Where's the phone? How do I call the nurse? Why do I have to keep the side rails up? Do I have to keep the side rails up? Does he have to wear a gown? Can he wear his clothes from home? Where can I go get something to eat? Is it okay to step away from the bed? How do I let you know that I'm going to step away from the bed? How long will you be gone with x-ray? All these multiple things that we can be providing information about. And then if they have to ask again, we know that's normal and expected, and we'll give them that information again. Or if it's complex information about how to get somewhere, we either want to have someone walk them part of the way, or we try to walk them at least to the elevator, or we write it down for them. Preparing for discharge at home, again, anticipatory guidance, asking about things they may need. Again, do they feel comfortable with changing the dressing on the leg? Is it someone maybe that's comfortable with healthcare that could be taught to do that? Do they feel comfortable with checking a blood sugar? If they don't, then we need to make sure that home health is going out, or making sure they follow up with the physician earlier than maybe they had intended to, just to verify that they are that they are checking it correctly. Okay. When's my follow-up appointment? Who do I call when I get home if I have questions? Who do I call if I get home and he's in pain or he's sick? Or what do I do if I get home and he starts having trouble breathing again? All that participatory information. A lot of that is already printed on our discharge paperwork. Again, things like appointments, how to get in touch with people for appointments, who to call for questions, who do I call or contact about a doctor's appointment or something that isn't urgent, and then who do I call or what do I do if something is urgent or emergent. So outpatient and ambulatory care, and I know Jackie had talked about this some the other day as well, of saying that there's still anticipatory guidance. There's still making the outpatient setting atraumatic and getting down to the developmental level of the child and explaining what's going to happen and allowing them to learn about what's going to happen based on their teddy bear or them having a dressing on their teddy bear, all those types of things. And so one of the disadvantages, I think, to outpatient many times, not always, but is that things are kind of rushed in that they may not have always had time to learn about the facility or had time to come and walk around or had time to really know and see the people who they're going to be seeing later, and that like they may have if they got to come to the hospital and see where they're going to be or watch a video of the hospital or something like that. But benefits of ambulatory are that they're not going to be there very long. So coming in and getting acclimated, parents being able many times to stay with them until they're sedated or until they go to surgery, and then them waking up and being able to have parents there and then going home to a comfortable environment. So the things you bring for comfort may just be a few things to keep them comfortable while they are anxious about going to surgery, when they are recovering briefly, and then on the ride home. Preparing them can be a challenge again because we are in a hurry. It's not that we aren't patient and that we don't want to answer questions, but you may be taken into this room where we're going to get you ready for surgery, and then it's only going to be a brief period of time, and then we need to take you to another room. So that period of sitting in one place and getting acclimated to people's faces and what's normal and all those kind of things, they may not have that opportunity, that time. The stress of waiting as well. So coming to an ambulatory or outpatient care, it could be that parents have signed them in and then sitting in the waiting room and then waiting for the next part and then going to where they're getting prepped and then waiting some more. And so kind of waiting and thinking about what's going to happen next. A great way is for the nurse, the physicians to come and introduce themselves, to talk about what's going to happen next, to be starting to give education and information, answering questions about what's going on. And then explicit discharge and follow-up instructions. Again, we haven't had the opportunity of being able to discharge, give education and information for days. So what do I need to know? One of the great things with ambulatory and outpatient care that I've found is follow-up phone calls. So letting parents know that the nurse or someone is going to follow up with a phone call 24 hours, 48 hours, however they do it. And also calling to ask the parents if they have any questions, how the child's doing. So being able to kind of meet that gap of we got home and now I don't remember what they said or what to do, or they seem a little warm, but they don't have a fever. Is that okay? Or they got sick once. Is that okay? So making sure that discharge instructions are discussed, they're in writing, there's phone numbers of who to contact if they have questions. And then also that follow-up call is great to be able to see if there are any other questions or anything like that once they get home. So we know that some patients need to be put in isolation. We talked about some communicable diseases, and not every communicable disease has to be hospitalized, definitely. But let's say we have the patient who has rotavirus. They've got a GI problem, they have lots of diarrhea, and they become dehydrated. So they need to come into the hospital maybe overnight to even get rehydrated. They're going to be put in isolation. So one of the things that the book talks about is talking to parents, talking to the child about all this funny stuff that we got to wear. So talking to them about the hat and the mask and the gown, and even maybe letting them have a mask or putting a bonnet on them and letting them see that they're not scary. One of the other suggestions is that most isolation rooms that I've encountered, that I think most all of them, when there's an isolation door, before you walk into the room through the isolation, there's a window. And so it's a great idea, instead of putting all your stuff on, your mask on, then knocking and going in, really recognize who you are with just your eyeballs, if you can knock on the door, the window, let them see your face, say hi, put the mask on, and then walk in. And then be able to have them recognize that it's you coming in. Extremely important as well that we don't avoid going in rooms simply because we got to put the PPE on. And I know nobody intentionally does that, but what happens is that people tend to not go in rooms as often because you have to put all the stuff on. And we tend to want to group care together. Well, I have to go in there to take this medicine. I might as well go ahead and check their blood glucose while I'm in there. I might as well hang that other bag of IV fluid while I'm in there. So intentionally, to avoid exposure to isolation and those kind of things, we group care, which is fine, but we want to make sure that we're not isolating them. So even if we go in and we don't have care to do, if we see how they're doing, if we check on them, knowing that toys that are in there as isolation have to be toys that can be thrown away or that can be wiped clean. Okay, it can't be other toys from the kind of the toy room in the hospital that are brought in and brought back out. Stuff, things that plush things and all those kind of things. Children may have limited understanding as well. So again, seeing the scary things like that, not understanding why the last time I was here, I got to ride in the wagon and go out in the toy room, but now I can't. So helping them to understand as much as possible that maybe they're in this room this time and they've got some germs that are making them sick to their belly, but it's important that they are in this room so we can get rid of the germs here, and so they can feel better to be able to go home soon. Some of those type of things based on, again, their developmental level. When we think about isolation, we tend to think about like contact precautions, but a child who is in traction or immobile or those kind of things can feel just as isolated. So we may leave the door open or things like that. We may come and go as much, but helping them to stay oriented. So especially if we're talking about a school-age child or even an adolescent, you got to have a clock, so you got to know what time of the day it is. Making sure that the shades are up during the day so they can see it's daylight out, closing the blinds at night. You can even move the bed closer to the window so they can see out, all those types of things to help kind of decrease that isolation feeling. Even like we said, if people coming in isolation gear all with the door shut, or just me not being able to get up and move and get out of here, which can be difficult. Dealing with a child's fears, again, their fears many times can be related to all this stuff that we're wearing, but it can also be fears of, am I going to be able to get up and walk? How long am I going to have to stay in the bed? And then potential for sensory deprivation. So that's a huge thing we think about with not only, I think with sensory deprivation, many times we think about things that we hear. So keeping the door shut keeps out some of the sounds, but also thinking about orientation to time. Like we said, with clocks, with calendars, knowing when it's daylight, when it's nighttime, making sure that we understand that a patient may be calling out more often and asking us things more often on the call bell because that they can't get up and go out. And so making sure we're talking to them that way and making sure we're coming in and interacting with them, even if we don't have specific things medically that we have to do, that we're just coming in and interacting with them and talking to them and seeing what they need. Emergency admissions are scary for children and for parents. So there may be an admission that is brief when it's an emergency. So coming into the emergency room, it may be assessing their airway, breathing, circulation, again, putting an oxygen mask on them. It could be stabilizing a child due to an injury or an accident. And so asking the big long list of history questions may not occur right at that time. We may be asking pertinent things related to the illness or injury, asking about pertinent history, medical history of the child, allergies, all those type of things that are needed in an emergent situation, but not doing the whole full complete assessment, maybe until they go to another unit or something like that. Many times we're also rushed, we're hurried in those situations. It used to be years ago that we didn't let parents, we didn't let significant others, those type of relations in the room if there was an emergency, okay? And so It may be that if the child was getting CPR, if there was a child that was in an injury, those kind of things, that we kept people out until they were at a certain level or stabilized. Now, we certainly do that at times now as well. If we have a child that the physicians are suturing, or they're getting x-rays, or they're putting in skeletal traction, all those things, they may not need a lot of people in the room. They may need privacy to do that as well. They may need sterility to do that. But we have parents, we have whoever their guardian or whatever is in the room to provide comfort during other situations when it is possible, because we know that's important. It's important for anxiety of the parent and child. It's also important for closure if it happens to be an end of life situation. So we also want to make sure that if it is a situation that we did them urgently, so maybe we had them come in urgently, we assessed them, we put a mask on them, we started an IV, we did an x-ray, we did all these things, and the parents were there, but we are not really talking every step of the way after the intervention. They call it post-intervention, that we talk about what we did. Okay, so we wanted to make sure we got ahead and got them assessed and put oxygen on him so that it could decrease that work of breathing, so it could slow down the heart rate, so he's not working really hard. And so afterwards, kind of sum up what happened and answer any questions that they may have. Participation of the child and family is appropriate. So again, maybe we want a child to put a nasal cannula on at this point in ER because they're a little bit tacky. And so it's a preschooler who's not so keen about you putting something in their nose. If we give them the time to look at it and maybe put it up to mom's face to see that it's not going to hurt them, and then let them kind of put it in their nose and over their ears, those type of things. If we take a couple of moments to be able to do that, then we can get a lot more cooperation than having to try to sit there and fight them for it and leaving them traumatized and them not trusting you and continually pulling it off. So assessing what's urgent, what's emergent, what we need to do. And then other times, even when we're in the ED, if we can allow some participation to help them gain a sense of control. Anybody else want to say anything about the ED or anything like that?
Mothers go nuts.
Yeah, I could imagine. Yes. Yes. Do you have a lot of parents that, and I hate to say it this way, but that maybe that you have to ask to step back, that they're too into.
Well, I've thrown them out of the room before on scene.
Okay. Okay.
Yes, especially nurse moms.
CNA moms, nurse moms. I had a patient that coded on, 18-year-old male coded on me. Mom was a nurse, couldn't recognize agonal respirations, and absolutely lost her mind. And I had to physically get her out of the room so that I could work.
Yeah. Yeah. Like you said, I mean, we want to be able to have patient or family parents involved in care, but if it's emergent, if there is some type of reason or that the parent is not enabling that care to go on, or even they're so overwhelmed that in order for people, like you said, to work and to be able to concentrate and those kind of things to step out, I think that's important. I think if it's one of the things that I've noted is if at all possible, if you have a coworker who can go with that parent, talk them down, kind of stay with them and give them some anticipatory guidance on that end, that will help them to be able to decrease that need of having to go back in there, wanting to go back in there, and also give them some sense of control about what's going on. I've kind of found that in end-of-life situations too. Like if there's so many people in there that they have to step back and they're overwhelmed, sometimes it's best to just take them away from the situation if they will, or even if they choose to do that, and then have somebody talk to them about what's going on. Yeah.
Well, on scene and even in the ER, if the parents are erratic, or like a couple of the infant codes that we've had, basically you just run in and you grab the child and you go. You don't care about the parents. You don't
Yeah.
telling them anything. You just doing what you do.
Yeah.
And then once the initial stuff's done, then they can come aboard.
Yeah.
But until then, I don't even really involve them. We didn't in the ER either. If somebody came in with an infant that wasn't breathing or something, the parents were secondary. And until we got everything done, the parents weren't allowed in. So
yeah, that's a good point. Some places even have like a chaplain or a social worker or somebody that can go out even to the waiting room or someplace and kind of fill in the parents, keep them updated, assess things, even get information about things that so in certain situations it in all situations, I would say that the care of the child, the urgency of the care that's needed for the child is always priority. Intensive care, we kind of touched upon this, that it's increasing stress. Again, the child has not been in a situation like this. Parents may have never seen a situation like the ICU, and definitely probably have never seen their child in that situation. So answering questions about what is all this stuff? Is it okay for me to touch them? Is it okay to hold them? How do, what are all these noises and strange smells? And can I stay in here with them? If I can't, then where can I stay? Where's the waiting room? Or those type of things. All those type of anticipatory guidance about things to kind of set the path of how things are in the ICU. Meeting the family's emotional needs, answering questions, acknowledging, I know this is really upsetting for you. I know that you, that like you said, you must feel overwhelmed right now. So parents' need for information, again, taking a cue from them of how much detailed information that they want. It could just be a parent knowing what's going on at this moment, what they're doing for the child, what's safe for the parent to be able to help and do, to somebody that wants to know other details. So give them what's necessary. And then if they ask detailed questions or ask other questions, then you can bridge the gap and get that information. Remember, in situations, especially urgent situations, emergent ICU, parents might not be able to retain all that much information at that time. And then the perception of security. It says resulting from constant monitoring and individualized care. So again, we need to talk about safety in the ICU as well. So we'll talk about, Wednesday we talk about respiratory, we're going to talk about more about oxygen. And so we'll talk about some safety mechanisms as far as oxygen, why it may look different to the baby that's in the NICU, to the child that's on acute care, to the child that's in ICU. How do we keep them safe? How do we teach parents about things that are norms? So we check their blood pressure. What should it be? Or what do we want it to be? Or what's that monitor mean? Or what does that number on the monitor mean? Or that you seem to be breathing really fast. Is that okay? And so kind of give them that information to give them that sense of security about kind of, is there something, is this what's the plan of care is? Have you seen this before? All those type of things. So also perception about security is, if I can't stay with my child, or if I have to leave and go home, how do I know they're safe? Parents all want to know that their caregivers are going to care for their children, emotional needs, safety needs, physical needs, just the way that they would. And so teaching them that maybe it's one-on-one care. Maybe it's that I'm observing them all the time from the nurse's station right over here. Maybe it's that even though I'm not standing here, I can see the monitor, I can hear the monitor. I'm checking on them constantly. When you leave that ICU door, that door locks. So if you need to come in, you need to ring the buzzer. We don't let anyone in unless they're approved to come in. So how do we, knowing safety mechanisms that are going on can help provide assurance that they are caring for the child just like a parent would care for them, and also security of when I step away, how do I know it's okay that I'm not here all the time? So I got a last question for you. It says, while orienting a new nurse to ICU, she asks, how do these children sleep and not become frightened with all the lights and the noise? So how should we respond? And this is a select all that apply. So we'll go through it one by one. First response says these children are sicker than those on the pediatric unit, so the noises and lights are really necessary.
No.
No.
No, and in fact, that's not even answering the question, really. So for one, that's not true. The noises and lights, they're necessary. There may be different noises and lights other places, but that's not, that doesn't make the reasoning that they're not scared or frightened or they don't have a right to be that because the noise is there. We try to organize care into clusters so that infants and children can sleep, and we can turn down lights.
Yes.
Yeah. So the book even talks about it, and I think it's in one of the responses coming up, is clustering care is important. So what that means is that if, let's say, lab comes in and they're going to need to draw blood, and we need to go in and, I don't know, maybe listen to lung sounds, bowel sounds, it would be good to do that while they're awake, or to be able to go in and ask them questions while they're awake or something like that, instead of waiting 20 minutes till they're asleep again and they go in and turning the lights on again. So clustering care is okay. I like what it says here about noises and lights, so we can turn down the lights. That's important. What we don't ever do is turn off alarms. So alarms alarm for a reason. And in some instances, the volume can be turned down at a certain level at a certain time of day in a room, but we don't ever turn off alarm sounds just because of the convenience. That they're there and they're important because we need to know when something is abnormal. Also says, oh, here it is. We silence alarms to allow for periods of sleep, especially at night.
No.
No, we don't silence alarms. When possible, we allow for uninterrupted sleep cycles for infants 90 minutes and older children 60 minutes.
Yeah.
Yeah. So you may not have read about the exact time level yet, but we want to allow for uninterrupted sleep cycles. We do, because if you're not getting rest, if you're not getting sleep, if we're waking you up, we're turning the lights on, all that, it's going to be more anxiety, more stress, more inability to cope, lack of coping mechanisms when we're exhausted, we're tired. And then we encourage parents to sit with and touch their children as often as possible.
Yes.
Yes.
Yeah. And again, we could read into that and say, well, as often as possible, they're in the ICU, maybe they can, but as often as possible, really meaning when it's appropriate to allow them to come in there. But yeah, parent-centered, family-centered care in the ICU, any environment, to allow them as often as possible to provide that care, that touch, that comfort to children. All right, any questions?
I didn't think anybody ever slept in a hospital.
We try to a little bit. One of the things I want to tell you is Wednesday, I've got 2 different lectures at that time. There are not 2 lectures, 2 chapters. And I've tried to avoid doing that as much as possible because, like, when we talk about cardiac and gastrointestinal, it's something I want you just to focus on at that time. So what I did is the chapter that is scheduled for Wednesday, that is children with sensory, cognitive and sensory impairment. So we're talking about Down syndrome, we're talking about autism. I voice-overed that. Doesn't at all mean that I might not do a brief kind of recap on Wednesday before we talk about respiratory, but I have that on voiceover that I posted for you to listen to. We're going to talk about just about respiratory on Wednesday, so that we can kind of make sure that we have a chance to really talk about it and spend a lot of our time talking about respiratory. Okay. All right. So I will see you on Wednesday.
Thank you.
Thank
Have
you.
fun.
Thank you.
Thank you.
Thank you.